Hello and welcome. Thank you all for joining us for today's panel, observing the 32nd World Day of the Sick. I believe we are actually in competition with the Super Bowl right now, but this is a very important topic and I thank you all for joining us. This webinar for World Day of the Sick is the first in a series for CHA titled Health on the Margins, as CHA looks to draw attention to those who often find themselves and their care needs falling between the cracks. Initiated by Pope John Paul II in 1992 as a way of remembering all those in need of care, this year Pope Francis has called on us to consider the important role of community and companionship for those who feel isolated and abandoned in their illness. The health consequences of social isolation and loneliness are significant across the age spectrum and worsen as people age. Many people found themselves alone during the COVID-19 pandemic. The patients who could not receive visitors, but also the nurses and healthcare workers and support personnel overwhelmed by work and enclosed sometimes in isolation wards. We know that social isolation enhances illness within the community, which impacts both the mental and physical health of people in need of our services and care, as well as those who work in healthcare. As people committed to better outcomes for the vulnerable, this panel is going to explore how we can work to better address the need for connection and companionship in our society to improve health and well-being. We are fortunate to have an excellent panel with us today who I will introduce before we kick off with some questions. If you also have individual thoughts or questions, please feel free to pop them in the chat and I or the panelists may respond to them if we are relevant and able to. So without further ado, I will introduce our panelists. We have Professor Tim Moss, who is the content manager at Healthy Male, which specialises in health and wellbeing for boys and men. Tim has a PhD in medicine from Monash University and more than 20 years of experience as a biomedical research scientist and academic. Kathy Jenkins. Kathy is the Executive Director, Mission and Leadership with Mercy Health. With an education background, she's worked in a variety of environments, including education system leadership with the Archdiocese of Melbourne and the Diocese of Sandhurst, and a publisher and editor and a leader of mission and evangelisation. Dr. Ian Sims is the Head of Pastoral Care and Volunteer Services at Southern Cross Care WA. He's also the project lead for the No One Dies Alone program, which was implemented through the company in research partnership with Edith Cowan University. Dr. Sims is also the recipient of CHA's Excellence in Pastoral Care Award in 2023. Dr. Mary McInerney is the Senior Manager of Pastoral Care Services at Villa Maria Catholic Homes. Mary has an extensive background of over 40 years in pastoral care. She has worked in education and currently in healthcare, where she joined Villa Maria Catholic Homes in 2016 and worked as an outreach worker in independent living. Thank you very much for all joining me today. I know that your wise words will be incredibly valuable on this really important topic that Pope Francis has called us to discuss on this World Day of the Sick 2024. So I thought I'd kick things off reflecting on Pope Francis's message and what this actually looks like in day-to-day life in your work. In his message, he notes that it's not only is connection an important part of attending to the needs of the sick, it is a vital part as we are geared towards this encounter as human beings. So I'm interested, I suppose, what your experiences in your work about how relationships have impacted the health and well-being of those you've cared for or looked after or sought to support. We might start with you, Kathy. What does that look like?
Thanks so much, Bridget. I might start with a story from one of our aged care homes, which I found quite humbling. I was visiting and there was an older fellow who had had a devastating stroke, so immobile, non-verbal, and sitting with him was his wife of over 50 years, feeding him soup with a teaspoon. And I sat with her and I said to her, "How is this for you? It must be so difficult for you coming every day." And she just put her hand on his arm and said, "He knows I am here." And it was a really powerful example to me of the importance of presence and companionship. Here was this fellow who, in the eyes of many, would be seen as worthless, but in the eyes of this woman, still made in the image of God, and to whom she was just still so powerfully committed. And I thought, here is this fellow trapped in a world we don't really understand, but always with his wife at his side, with the touch of her, and with having really good care. And I was thinking how powerful it was for both of them, and a learning for us as the carers as well.
Thanks, Kathy. Ian, you also work in this space, particularly with your No One Dies Alone campaign. Are you able to speak a little bit about that, and particularly the family relationships that you've seen really impact on the health and well-being of the people you and Southern Cross Care WA have looked to care for?
Yeah, thanks, Bridget. I think that aged care is a fascinating space insofar as we are seeing many of the relationships that sustained people in the past either no longer around or waning in their own right. And that creates all kinds of questions and uncertainty for people moving into aged care. I think what I've noticed is the power of relationship in terms of lessening the agitation that many elderly folk experience. It wasn't just in the COVID times, but outside of that as well, where a resident might be confused as to what is happening, and having a family member there or having a staff member who has got a compassionate connection with that resident, and suddenly the agitation levels start to reduce, and a greater calmness is coming in. Now, there's been no medication given that has created that. That's the effect of relationship that has made a material difference to that person in that room at that moment. And so, yeah, an incredibly powerful dimension of our experience as human beings is just the impact of relationship.
Tim, you come at this with a bit of a different angle, particularly for men and boys in Healthy Male. How have you seen this aspect of isolation, abandonment, loneliness, particularly impact males?
Yeah, well, we did a nationally representative survey of males a couple of years ago, Bridget, and we found that around 1 in 6 Australian males are lonely, and the men who are aged around 40, their early 40s, they're particularly lonely. About 1 in 4 of them are lonely. I think Ian hinted at this, that there are relationships that we may once have had with people that don't exist, or don't exist as strongly as they do now, as they once did. So as a consequence of that, people's relationships are less satisfying to them as they once were, perhaps. And even though you can be surrounded by people, if you don't have a meaningful connection with them, you can still be lonely. And for men and for women too, loneliness is strongly linked with poor health. I guess also in this way, I think about the work we do with Aboriginal and Torres Strait Islander people who don't think of health as being mental health and physical health and all that separately. There's spiritual health tied up in there as well. And I think we need all of these things to be truly well.
Thanks, Tim. Mary, we might go to you. Tim spoke about instances where even if people have individuals within their network, they're not connected, and it's not building that kind of healthy relationship needed. Villa Maria works particularly in independent living, but also has sites in homelessness, aged care, and transitioning people into aged care from homelessness. How do you support pastoral care workers, particularly as a manager, to build those connections with residents when maybe they haven't existed to the standard they need to with other people in their community. Oh, you're just on mute.
Is that
Yep.
right? Yeah, thanks, Bridget. I find my role as really essential in supporting pastoral care practitioners, helping people, as you say, build relationships. In particular, it does take a lot of time for that trust to develop, where people have been fairly, you know, socially isolated, some living in with mental health, or fairly alone, that they haven't got family support too. So the ways that I encourage, and even for myself, to build that relationship is about our quality of presence, that we are genuinely authentic when we are with the other person, that they get a sense that they are really valued, that they are welcomed at VMCH, no matter what their situation. And so that takes a lot of time to really hear their story, that we actually spend time, that they are listened to, that they are heard, and that we want to respond to their needs too. What is it at this particular time in their life that they actually need? And how do we actually then connect them with other people in the community if they want to? And I think even environment, our building spaces, has to have an impact on that too. How have we got space where people can gather? Recently, we've just built a new place at in Ivanhoe, Trinity Lane, and it's just ideal because we've got a community centre that the residents can actually come together to share a bit of life too. But how can pastoral care practitioners be in that space to encourage people to be attentive to themselves and to listen and connect with others so that they're not socially isolated as much? It's just so vital that we companion people in that space that they have known.
Thanks, Mary. I want to pick up on a point you raised around, I suppose a question I have is, how do you know if someone is feeling isolated or insecure or lonely? And you spoke about the power of listening to stories and engaging in that conversation so that you can pick it up. We might come to you on this, Kathy, because you have a background across education, young people, maternity, aged care. Mercy does such wonderful work. How would a healthcare worker assess what the needs? How could they assess what the needs of a person might be in this space?
Bridget, I think it's a really good question, because we have to have the eyes to see what's going on behind the presenting behaviours, I think. And there's a phrase that the Pope used in the letter for the World Day of the Sick, the therapeutic covenant. And I thought that was a really beautiful phrase, because really that includes the person in front of us, but also the people behind them, their family members, their other support workers. And I think we have to, I've observed in the work here at Mercy Health, how important it is that our carers and everyone involved with the resident or the patient has got the eyes to see what's really going on, because people give out a lot of clues about how they're feeling, but we've got to be able to hear them. Similarly with young people in distress, older people in distress. And I think it links a lot in with the conversations many of us have about end of life, for example. How do we really hear what's going on when people are wanting to think about and ponder what it means for their end of life? But I think that's also where the community behind the person is important as well. Many of our people, of course, are isolated and alone, but many of them also have like a network behind them that we also need to listen to. So it's how do we cultivate the ear of the heart, really, so that our ear can connect with the story behind perhaps the face of the person we're seeing.
Thanks, Kathy. I think it's important, and I'd be interested in your views on this, Ian. Pastoral care workers are so adept and qualified at picking these things up. I mean, it's their life's mission. They're so attuned to the needs of an individual in this way. But really, it's up to all healthcare professionals, isn't it? Wouldn't you say? And what are some of the skills and I suppose mechanisms that they can tap into within a facility to support their own upskilling to make sure that they're aware?
I mean, I think that it probably goes without saying that there needs to be an ability to listen and a delight in being able to listen to people and to watch. We're obviously watching the body language, we're listening to the word choice. There are all those kinds of factors that we are aware of in the dynamic of that encounter. But I guess that we're trying to also assess the strength of the relationship, and that relationship not only between the resident and ourselves, but between the resident and family members and God and the rest of their life and component parts of their lives. And that's, as soon as we start thinking about the strength of the relationship, that suggests two things to me. There's a positive side to that. The relationship provides strength. That would be the positive. The negative is that the relationship provides strength, but the strength is turbulent, it's unpredictable, emotionally expensive, and so on. And so when I'm working with residents and I'm trying to get a sense of the strength of the relationship with the family members, I'm looking at shall we call it the behavioral residue after the visit of family members. And so where there seems to be a generalized well-being after that visit, there's something good that has been transacted there. Of course, the opposite is true, that some residents are sadly worse off after the visit than before. But also, I'm assessing the residents' reporting and their interpretation of the relationship. But I'm also watching for referencing. So what I mean by that is, in the conversation that I'm having with the resident, where does the person keep going back to? If the person keeps going back to a particular family member, the referencing that's taking place there tells me about the importance and significance of that family member in the relationship matrix that the resident has. And so it's really watching for the signs in the moment, but you're also trying to read interpretations as a result of encounters that resident has had with family members along the way. I don't know if that goes some way to starting in on an answer to that.
It certainly does. And I might come to Tim on this. Because I think Ian raised an important point, is that there are relationships and relationships generally are hugely beneficial and critical to an individual, particularly when they're ill. But there are some instances where relationships that an individual might have are not conducive to their flourishing and their well-being. How is that manifested in men, and what do you do about that when the relationship isn't necessarily a good one?
Yeah, well, first off, I think about this in terms of work for lots of people. We know that high levels of loneliness in men are linked with feeling like you have a poor work-life balance. Now, most people work in jobs that require their interactions with others. You know, if you're a salesperson, you're dealing with many members of the public, perhaps if you're in retail. If you're in an office, there's a team of people around you, and even when we're all working from home, there's still a team of people that you can reach out to. But if the quality of those relationships is not sufficient, if they are not providing you with the emotional and personal support or currency that you need, then you can still be lonely. So it's the value of that of your relationships that matters, and it might just be a relationship with one person. For many men, it may be their partner. So long as men have enough satisfaction from their relationships, they can protect themselves from being lonely. Men tend to have smaller social networks than women, so that may provide some restriction on how much wiggle room they have if they were to lose a friend.
Thanks, Tim. I might jump back to Kathy on this, particularly as Mercy works extensively in maternity services and with women and families. Obviously, there are legal requirements and reporting mechanisms that are quite serious and straightforward when it comes to particularly difficult relationships that might be observed. But from a pastoral approach, how is that supported within Mercy that you've seen?
Yes, look, it's a complex area because one person's truth might not necessarily be the truth. So on a pastoral level, we would work very closely with the patient in our care, because that is the person who is our priority. And of course, there are many compliance and legal issues that we would follow their natural paths. But I think it's important for anyone in that situation to know that when they're in our care, for example, they are our priority and their story becomes our story, because they have to feel safe, they have to feel supported. And this is where I think the work of the pastoral carer has a particular place to play in health. This is not dissimilar in the education world, where people will say, oh, all teachers are pastoral carers. Well, yes, but at the same time, the pastoral carer has a particular set of skills that they can apply on that one-on-one relationship with somebody who, when they're already ill, is vulnerable. We use that word a lot, but no one's at their best when they're unwell. So I think our priority is always to work both to complement the clinical work with a really strong pastoral personal approach, and to make sure that that person feels that with us they are safe and that we hear them and that their story becomes part of the story, that becomes our story.
I might get you to reflect on that, Mary, particularly as Trinity Place, which you referred to before, has a specific desire to look after vulnerable individuals and women who are at risk of homelessness in their older years. How does the pastoral approach support the clinical approach there?
I would say that we work very much in a multidisciplinary team, and then even say in aged care, people that are aging, that we go to, say that we call it huddle every morning, handover, that we're actually listening to what is really vital for different people that might be struggling, especially with physical pain or towards the end of life too, that we then can come in and really stay with. I think staying with is quite crucial when people are suffering or struggling, say even at Trinity Lane, that we can keep going back, that we're not going to abandon them, that they are respected, that their story will be heard, and that we can advocate at times on behalf of them. Some people maybe with you know, coming into aged care also, they're quite isolated. That's a huge transition, leaving independent living. But when we're working with people who are living independently and they raise that issue of, well, what's going to happen to me, you know, when I need to go to aged care, at least we can offer support in that transition too, that they're not alone. That we will be there to support them, because some people, have not got families, and I think that can be really difficult for them to even, well, the transition into aged care is a huge one, but how can we welcome them and support them even with the paperwork, because that's even huge in itself, but that we're there for them too. Yeah.
Yeah, thanks, Mary. I think, you know, reflecting on even my own family members, they talk about when they went into aged care, having to see a lot of their friends pass away.
Yes.
Their network slowly reduce as they get older, and how difficult that can be for an individual, or family members passing on. They might be the only sibling left. So that comes with it some difficult terrain. I wanted to pick up on a comment that Ian made earlier in the webinar around the impacts of COVID, and obviously social isolation in some of these healthcare settings, and that loneliness or that feeling of abandonment when you're ill has been ongoing long before COVID. Do we think that it was, and I might come to you, Tim, on this, do you think that these issues were brought more to the surface in COVID? And have we learned our lessons from that? And is more being done? Is it on the front of people's minds more now?
Yeah, I think what the trouble during COVID did was point out the scale of the problem. You know, people often, you can be very close to the edge, and it just takes you something small to be pushed over, right? Well, COVID was a pretty big push, and a lot of people definitely struggled with that when it comes to loneliness and connection with others. But we know from studies that have been done over 20 years in Australia that loneliness is quite prevalent, and we know that it's tied up with different social factors, with people's health and well-being. So every cloud has a silver lining. I guess we're lucky that COVID shone a light on this. And, you know, we're seeing now, it was only 12 months ago that the chief medical officer equivalent in the United States published a treatise almost on loneliness and its effects on health. So it certainly has raised awareness.
Ian, do you find that with the onset of COVID, and I know aged care facilities are certainly still suffering the impacts of that, did Southern Cross Care WA have to adjust how they operated, or how they picked up on these things, or the care that they provided during COVID? And what did that look like? Has that remained in place, or has it been unnecessary?
Yeah, the COVID experience, I think, for everyone just changed the landscape entirely, didn't it? As Tim said, it took what was already there, and it exacerbated it to the point that we became aware of just how vital it is for those relationships to be in place. We've taken those relationships for granted. The moment it was taken away, we suddenly realized just how powerful it is to have that human contact. I remember sitting with a gentleman in the community sometime after COVID, and every time I used to visit him, the conversation would circle back to the fact that he was not able to get to the side of his wife while she was dying in some aged care facility. It wasn't one of ours. And he had been prevented from getting to her side. And a man who had been married for over 50 years wept every time he got to that point in the conversation. And I thought of that in terms of just how marked he was by that experience. And relationship was what he was counting on to be able to convey so much of the love that he had for his wife and to celebrate their relationship, and he was denied that. Now, we hear stories of of that kind of thing happening in various parts of the world, and it saddens us. I think as a company, we learned huge lessons about how to manage that kind of thing, trying to deal with compliance on the one hand, the instructions from health departments and all the rest of it, and trying to preserve basic humanity in the midst of it. I don't know whether we succeeded or not. I think we did our best. Certainly within pastoral care, we were trying our utmost to make use of technology to try to interface residents with their families. But there were a lot of people that wondered what was going on. They're seeing these people come in PPE outfits. What is this? They don't recognize people because the facial features are all obscured by the gear. And just the anxiety rose exponentially. And so to try to move into that space pastorally to lower the anxiety level was, I think, one of the key gifts that pastoral care was able to give in that place. But I really do think that as much as there was a negative side to COVID, the positive is that it highlighted our absolute necessity for good relationship. And that's come home clearly, I think.
I can hear the passion in your voice when you reflect on that period of time, Ian, and it spoke to me.
It was hectic.
Certainly spoke to me. I found myself in hospital in ICU during COVID, very isolated, and the pastoral care and the healthcare staff, certainly having them equipped with providing support there was very important for me. I might go to you, Mary, on this. Was that your experience of the COVID era? Have certain practices remained? And I think particularly for those at-risk groups, so people who have already experienced some level of trauma, who are coming into care at Villa Maria, how do you provide that added level of support that something like COVID might be have quite an impact or a triggering response from them?
I agree with everything that Ian said, and this has been really traumatic, and especially the PPE. It was a barrier. People could not, especially the aged, see people's face and even hear people at times, and they then became concerned for, say, the multidisciplinary team that we work with, pastoral carers also. It was just really escalated, that barrier between us, that we couldn't be present, and even touch. I think the whole thing of touch and what Ian described, especially towards end of life, at least we were able to have people in to say goodbye to their loved ones when that was happening. But at the same time, even to have the mirror, the window, to talk through a window was quite traumatic too. And I guess we were able to reach out to the more vulnerable in our affordable housing, because people would ring us. They were aware of their neighbours, so there was still a sense of community, but there was a lot of fear also of the unknown. So when we did hear of someone that was struggling, even to take them some food, to reach out on that level was so important too. And especially, I know on sites when COVID, did hit our sites and we had to have closure, we were very fortunate to have a team of people that rang the families every day, just to say what was happening. And I think that really helped to build a relationship so that we knew and they knew that their families were being cared for. And even at the end of that, say 2 weeks, to send a card to the family, that we did recognise that it was a hard time for them and their loved one. But for the more vulnerable, it really isolated people a lot more, and they then lived with a lot more fear and uncertainty about the future. So how do we offer hope in those times too, that, we're still here for you. You can ring us, we can reach out to you also. Yeah, but it was very challenging.
And Kathy, was that your experience as well? I think Mary drew on the idea that we're caring for a patient or a resident, but really you're interacting with a community as well. How do you balance those two when something like a pandemic hits? There's those physical barriers of PPE, and what lessons do you think have been learned on the provision of care and pastoral care in that instance?
Well, actually, Bridget, it's just reminding me, I joined Mercy Health just towards almost, I guess, we were well into the pandemic by then, but one of the first meetings I was involved with when I started was looking at larger name tags for our teams in aged care so that the residents could read people's names. And it seems like such a simple thing, but it was one of the learnings along the way, because the PPE was really confronting for older people, especially people who had that dementia. That was very challenging for them. The other group, I guess, to mention is it was extremely traumatic, and we're still seeing this in health with our team members, the staff, the team members who are working with patients and residents, because I think there was a feeling that they could not offer the level of care that they wanted, but then the grief of not being able to have loved ones around the bedside, or people having to give birth without a loved one with them. I think a lot of our team members still carry that really deeply. So organisation-wide, I know Mercy has done a lot of work to support our healthcare workers with working through some of that trauma. I think people still carry a lot of that with them when you visit now, and when I talk with some of my colleagues, there's still a lot of sadness about what happened during those years. Another early experience when I started at Mercy, similar to what you were just mentioning, Mary, was we had one of our homes have to go into full lockdown again after they'd been in lockdown. They'd just come out, and an email came around late Sunday afternoon to all the executive with a list of families for us to phone, which we did, and then kept in touch with those families over the next few days, because it was a really challenging time for the families as well. But I would agree that the great learning is, I think we've improved our communication, we've refined how we work we've refined our processes, and I think we've probably got a better sense of how to support staff in other traumatic circumstances as well, with debriefing, with employee access process support, and the pastoral care team have become a real focus for some of that work as well.
Thanks, Kathy. I might jump on that topic now about how we care for the carer who can also experience isolation. And this can extend to the healthcare workforce, but also individuals who are caring for loved ones. Tim, you spoke earlier about that work-life balance and the impact it has on men. I'd be interested in an outsider's perspective here, given everyone else here works within Catholic health facilities. What are some things that are useful and incorporated, and that we're maybe seeing more of, or some good ideas around creating a better balance, recovering from that COVID isolation that the workforce felt, particularly given the healthcare workforce. There's a lot of fatigue, there's a lot of burnout.
Yes.
What does that look like now, and how can we improve?
Well, I have a personal anecdote, really, more than something through work. My sister's a social worker, and she was managing a project at Peninsula Health in Frankston here in Victoria, looking at staff mental health and how to support healthcare workers. The project began prior to COVID, went through COVID and came out the other side. And, you know, just as somebody from the outside looking in, it's a terribly difficult problem to solve. I think that what's needed is building of resilience in healthcare workers so that they have the tools, so that they are capable of dealing with some incredibly difficult circumstances. And, you know, it's not just COVID, there's all sorts of traumatic things that occur to healthcare workers as a consequence of where they're working. And we need to better prevent the damage to healthcare workers as well. Now, I don't know how you manage that. You know, you think about on a work site, making sure there's signage and all of those sorts of things. Those don't seem to occur to the same level in healthcare as they might on a building site. And, you know, I think we probably have to think about what we can do like that to prevent against what really is a mental injury, a moral injury in healthcare workers.
Could I add something in there, Bridget? You know, one of the things that I've wondered about is in terms of the loneliness of staff, is that there is often a great fear of tripping over the rules, and then the backlash that will come from that. And so some staff have a real anxiety over, I hope I'm doing this right. I don't really have too many on the ground indicators as to whether I'm doing this okay. And what that leads to, in my opinion, is a further isolation and loneliness. I know that isolation and loneliness are two different things, but they feed off each other. But that's a component that I've noticed amongst staff. And to try and address that is probably a company-wide thing. It's part of the culture of a company, an ethos of the company that is not that doesn't foster a blame culture, but rather one that's supportive, where let's do this together and figure out how this is going to work. So I just wanted to throw that in there as part of that equation.
Yeah, I think that's so important there. Mary, I might come to you on that as well, just because this idea of looking after staff, pastoral care workers provide pastoral care not just to residents, but often to staff as well. What's been your experience in that space?
Yes, we do offer it to both, but essentially to residents. But there are times when staff really need to be heard too, and allowing space for them. I think the important thing is team building. I know for myself in pastoral care is that, you know, I might have 25 pastoral cares over 13 sites, but that they are not so much isolated in their site, but we are a team, and to work together as a team to support the team. And especially through the COVID pandemic, when usually we would have face-to-face meetings and then it was on Zoom, it was completely different. So how did I support pastoral care in that space was to create space and be creative in that space too, where the pastoral care practitioners had time to reflect in a creative way about what was actually happening to them and other staff on site too. What were their experiences? So we did have time where we would come together and people would share that. And since then, what we've done, and it only started because of COVID, was that in 2 of our zones, we continue to meet weekly now, even if it's for 15 minutes. So we get a sense of team supporting each other and reflecting or having a prayer. The other thing that I found really helpful was that on one site where we had to lock down for a few weeks, even a few months, was that our CEO with other staff, regional managers, even our legal team, our auditing team came in, and there was space so we could hear each other. What was it actually like, and what are our learnings? Of course, we made mistakes in and on sites, and that was the reality because it was so unknown. But what are our learnings so we can help each other to move ahead too? So I think that was really good too, that we weren't just alone, that we still had that support from our, wider team too. Yeah.
Thanks, Mary. You spoke about the concept of creating space, and I think that I was reflecting on this in light of Pope Francis's message, where he talked about individuals' relationship with the environment and how important that is. And I was thinking about a recent trip I did to a Catholic health facility that was new and has just got this beautiful environmental space that they've carved out to assist people essentially with their recovery. I might come to you on this, Kathy. Environment is such an important part of well-being. How do healthcare facilities encourage that relationship people might have with their environment, and a healthy one?
Yes, this is a question that we're pondering at Mercy Health at the moment, because we do want to surround people with beauty, because I think that helps the healing of the spirit. And I notice when we travel to our aged care homes particularly, there's a lot of energy goes into the gardens, spaces for residents to sit. There are a few places that have got raised beds where the residents can create their own little areas for growing plants and flowers, and having aspects that look out. And I know that, for example, we're in the process of working with state government with a new facility at Werribee, a new emergency department, and there's a lot of emphasis on providing a really welcoming internal and external space. I think this is a really probably, it's under-resourced, but also probably something we don't appreciate enough about just how important it is. And I was actually speaking at a meeting recently, and I said, imagine if every single patient and every single resident every morning woke up to something beautiful. I think we have to continue to invest and develop and think about what that looks like, as well as taking really seriously our responsibilities when it comes to the stewardship of what we do in terms of trying to make improvements with our strategy around Laudato Si and Laudato Deum, for example. But work in progress for us, and think it's just incredibly important for the human spirit.
I might go to you on this, Ian. I visited a facility once. Speaking of just those moments of beauty, I think that a lot of people think that before they get to aged care, their view of aged care is that it's this dingy place that they're going to be abandoned in. And I think particularly younger generations don't have enough exposure to aged care facilities and what they actually look like. But I went to a facility once, and they had this beautiful, it was in WA, beautiful sundowner event in the garden every Wednesday afternoon, where they had sparkling wine. I think it was non-alcoholic, but sparkling wine. And people used to get dressed up, and it was a really lovely kind of festive event. And I just thought, you know what, that's how I want to spend my last few years on this. How does Southern Cross Care kind of create those moments with the environment?
Yeah, so I mean, we obviously have facilities that were built many years ago. So there is a limit to what can be done environmentally with the architecture of the place. And so I suppose it comes down to events within older buildings, maybe, that try to rekindle that connection. Because really, I mean, I think the theme of today is about relationship and that encounter. And so if we're looking at those moments, there will be times that staff have got the residents together more along the lines of trying to shift the paradigm from institution to home. And the moment we make that shift, that I mean, I love the expression that the residents don't live in our workspace; we work in their home. And that has always been a very helpful understanding as to how we try to create those moments. And some of them are planned, some happen more spontaneously, to be able to enliven those home moments. Because I think that's what you resonated with, Bridget, is there was just a sense of home. And those are lovely. And that really is about relationship, probably more than it is about decor. But decor can certainly help.
Yeah, I think we certainly have to create and be active in creating the environment essentially there. I might come to you on this, Tim. What have you seen in terms of when we talk about creating the environment? We've seen the success of things like men's sheds and how they work, and we're becoming a bit more innovative with it. What are some other examples of that and what we're seeing manifest there?
I was interested with what Kathy said about the environment around the emergency department. You know, if you're going to an emergency department, you're already stressed, right? So ways in which you can provide people with cues that they are safe, that they will be looked after before they walk in the door are really important. We know that men's health behaviours are different depending on the type of health service that they're accessing. And some of that has to do with how welcome they feel in those spaces. So the built environment in terms of health services matters. The natural environment matters. We know that people who spend more time outside in nature generally are more healthy than people who don't. And then when you're designing environments for people to support their health, sometimes you don't even realize what you're building is a health service. And that's what has really happened with the men's sheds. They were there as a point of social connection for men, older men, and it was very quickly realized that they're actually really good at supporting health and well-being of those men, because it provides the men with an environment that they can sort of identify with. It provides them with the camaraderie that they need. And it also provides them with a distraction, so that when they're talking about something that's really important to them, the person they're talking to isn't sitting directly across from them. He's working on the same project side by side. And, you know, that's an environment that particularly caters to the way that men communicate and build relationships. You know, think smartly about, you know, what different groups in our communities require in order to foster their relationships with each other.
Yeah,
I have to quickly jump in, Bridget, with a plug for small household living, which I'm sure that other organisations have it as well. But it creates this beautiful community opportunity around like a communal living space, but in smaller blocks of maybe groups of maybe 6 to 8 residents. And I think just picking up on what you said there, Tim, it's a beautiful opportunity to create a community. And sometimes when I'm out visiting and you go, they're making scones for morning tea, and it really does make a huge difference to move from being an institution to a home, as you were saying, Ian. Sorry, Bridget, just had to put in a quick plug there.
No, that's fine. That's absolutely fine. I was just going to say, I think that we you know, it was interesting what Tim said. I think different cohorts require different things sometimes, and there's always new and innovative ways to explore that. And it's not always about the facility or how old it is structurally or architecturally. It certainly is about that feeling of community that is being created. And Mary, you spoke about this a little bit earlier, like with the construction of new buildings, although they are new in this instance. Creating those meeting spaces, are they organic, or are there facilitated kind of community aspects about it?
I think it's both. It's like there is space that we have created, and then it's about people, even residents, taking the initiative. Like at Trinity Lane, like one of the guys has started up a barbecue every month. Another person runs meditation, but how did the pastoral care worker come in and listen to the needs too, and to build a sense of community? And just to say too, in aged care, I think our dementia-specific wings are so important to create also an environment where people feel at home and safe, and that they've got like lovely old cups and saucers or jewelry that they can actually feel like, well, this reminds me of something of home of the past. Or our place at, say, in Prahran, O'Neill House, which is a 22 bed for palliative care, end of life. And when I go there, and I just get a sense of peace and calm, and that people can look out on the environment, that there's a sacred space where they can go and pray, to be silent, but it's really peaceful. And I think we have to work at the environment where people feel at home, and that they can just be how they need to be too. At Greenvale, Corpus Christi Greenvale, a home for homeless men, that they feel, well, this is their home, and they can be there the way that they need to too, in all their humanity, their brokenness, their struggles, their pain, but we offer hope and love in that space too. So environment, I think, is essential to build a sense of community and connection. Yeah, that we're not just in our rooms or in our units too, but we have greenery, and yeah, that's our home. Yeah.
Thanks so much, Mary. And we might finish there. I want to thank our panelists, Mary, Kathy, Tim, Ian, for all your insights today. I mean, I think that was a really lovely note to finish on, some of the amazing work being done. You know, when I go into aged care, I'm now hoping for, you know, weekly barbecues, few sundown drinks, a couple of activities in the community room. So look, I think that you've provided a lot of inspiration as well today. So thank you very much for your participation in today's panel for World Day of the Sick.
Thank
Thanks,
you,
Bridget. Thanks,
Bridget.
everyone.
Mm.